services. They want to cover healthcare delivery models and methods for paying Medicaid providers. And so because of this flexibility, Medicaid really looks very different across states. In addition to being a critical source of health coverage for individuals and families, Medicaid is also a critical source of funding for healthcare providers, particularly larger health systems like hospitals and community health centers or federally qualified health centers. In addition to being reimbursed for providing care to Medicaid enrollees or Medicaid patients, these types of providers also receive additional or separate Medicaid funds for serving uninsured individuals or individuals who might be eligible for Medicaid but not enrolled yet. And so Medicaid is really a critical lifeline, I would say, both for individuals and families as well as for healthcare providers in communities and states. So this is a graphic from the Kaiser Family Foundation that I think just really nicely and neatly shows the critical role that Medicaid plays. At the top line is the way it provides coverage and care to individuals, and then beneath that is how it helps states and healthcare systems be a critical source of health care. Okay, so let's then get into who Medicaid covers. So initially, when the Medicaid law was passed, it was intended to serve children, pregnant women, and individuals who are elderly or individuals with disabilities, or what's called the aged, blind, and disabled category. To be eligible for Medicaid, someone has to be a resident of that state, and for the most part, a US citizen or lawful permanent resident. Lawful permanent residents also have to wait 5 years after gaining that lawful permanent resident status before they can receive Medicaid as a result of a welfare reform law that was passed in the 90s. However, in 2009, a law was passed to allow lawfully present pregnant women and children to receive Medicaid without needing to wait 5 years. So there are some individuals with immigration statuses, such as visas, who can get Medicaid if they're currently pregnant or I think under the age of 18. I also want to point out there's a population known as dual eligibles who are eligible for and enrolled in both Medicaid and Medicare. And so dual eligibles can either be individuals who are over 65 and have low incomes, as well as individuals who are under 65 with certain complex health conditions and also have low income. And then the category number one, which I'll get to in another slide, is that in states that have expanded Medicaid, you can be just a low-income childless adult and receive Medicaid. But in non-expansion states, single childless adults are still ineligible, and so you still have to be low income plus another type of population eligible criteria. So being low income and also a parent, or low income and also pregnant, are still the eligibility criteria in non-expansion states. So what types of services does Medicaid cover? Medicaid is an incredibly, I would say, comprehensive and affordable program. It covers a wide swath of benefits. I would say coverage is more generous or more comprehensive than private insurance and Medicare in some ways. And it's also much more affordable than private insurance and Medicare in that most Medicaid enrollees don't have to pay premiums or co-pays, or if they do, those premiums and co-pays and out-of-pocket costs are very small amounts. And so typical, I would say, to most forms of health coverage, Medicaid covers your typical doctor's office visits, care you receive in a hospital, laboratory and x-ray care. But then it also covers things that private insurance and Medicare does not cover, including transportation to the doctor's office and nursing level care, long-term care. Medicare notably does not cover care received in a nursing home or long-term care services. Medicaid does not cover everything though. Notably, I would say prescription drugs is an optional Medicaid benefit, although all states do cover prescription drugs. And then it also doesn't cover dental care for adults, vision care, and care related to speech, hearing, and language disorders, among other optional services. And so what's Medicaid expansion? I just want to talk a little bit about the difference between traditional Medicaid and Medicaid expansion. So as some of you may know, the Affordable Care Act expanded access or eligibility for Medicaid in three significant ways. It increased the types of populations who could be covered under Medicaid. It increased the income eligibility limit for those populations, and increased, or for all populations, and increase the amount of funding states could receive if they decided to cover the new Medicaid expansion population. And so, as I reviewed on the previous slide, prior to the Affordable Care Act, Medicaid only covered certain populations who had very low incomes. And so covering pregnant women, children, individuals with disabilities, and some low-income parents, all those populations under the red part of the umbrella. And then post the Affordable Care Act, it increased not only the income eligibility for those populations, but then also increased eligibility to all adults at that income eligibility cutoff, or 138% of the federal poverty level. And so those categories under the blue part of the umbrella became newly eligible as a result of expansion. And so by increasing the income eligibility, more parents became eligible, but then by allowing any and all adults up to 138% of the poverty level, just a single childless adult could also be eligible for Medicaid. So why is Medicaid and Medicaid expansion important? Research has shown over time, research both prior to and after the Affordable Care Act has shown that increasing access to Medicaid both reduces the number of uninsured, increases access to coverage, obviously, but then increases access to health care as a result, including preventive care. In doing so, it's been shown, research that has specifically been done into the Medicaid expansion program has shown an increase in overall health by improving certain health conditions, or increasing preventive visits such as well child visits. It's increased the ability of individuals to get their chronic conditions detected. It's reduced tobacco cessation rates. It's increased access to mental health and behavioral health services. So there's been notable increases in diagnosis of depression and treatment of depression. Yeah, Medicaid has been shown over time to improve not just access to health care, but overall health conditions and overall health. It also, by allowing people to access health coverage while they're sick and even as their income increases, Medicaid has been shown to really improve economic and financial security. It helps individuals stay employed, find employment, by helping them stay healthy throughout those processes. And it has also been shown to be a big benefit budget to state budgets by helping individuals stay employed, and it just helps increase the labor market and just the amount of money being put into state and local economies, as well as helping hospitals who sometimes have to put out their own money, or states have to put out their own money for uncompensated care. Hospitals are better able to stay financially afloat and serve their communities as well. And then the final thing that Medicaid has been shown to do is reduce coverage disparities and health disparities. So because Medicaid has been critically important in those ways, at Community Catalyst, we've been tracking either attempts at the federal or state level to undermine the Medicaid program by introducing barriers or cuts that would make it harder for individuals to get the health care they need. The three main categories of threats that we watch are cuts to eligibility, cuts to overall funding, and cuts to critical benefits and services. Since coming into office, the Trump administration has introduced a few policies that we think would hinder access to coverage and care. and we've been tracking them closely over the years. And so in the cuts to the eligibility bucket, one thing that we've been watching was the introduction of a work reporting requirement policy. The Trump administration allowed states to introduce these policies, so a state has to decide to introduce it on its own. And it's really just an extra administrative requirement requiring people to prove through submitting paperwork or otherwise, or some other type of reporting, that they're working, looking for work, or exempt from a work reporting requirement. We think these requirements are harmful because they are just an additional barrier or administrative hoop to jump through. They don't help someone find work or continue to work. They really just will threaten to have someone lose coverage for failing to just meet an administrative requirement. A lot of states had applied for and received approval for work reporting requirements in 2018 and in 2019, but thankfully some litigation has halted implementation in some states, and then other states have decided not to go through with implementation because of the litigation. But right now, I think there's one state that was planning to go forward, although I'm not sure if they're still planning to as a result of COVID-19 and given the amount of people that are losing work and enrolling in Medicaid as a result. Another policy that the Trump administration introduced is allowing states to cap the amount of Medicaid funding that they receive and have to work with. We were concerned about this proposal because we think states should be able to have access to the amount of funding that they need for their Medicaid program and not just cut it off at an arbitrary point. And especially in times like these, where a completely unprecedented or unpredictable event has occurred that has caused an increase in Medicaid eligibility and enrollment, we think it's definitely bad policy to arbitrarily limit the amount of funds available for Medicaid right now. But again, thankfully, no state, just one state has shown interest in taking up a capped funding proposal. And then the last one I'll mention is that the Trump administration in their budget, in the president's budget, has put out, I think 3 times now, in each president's budget that they've done, they've signaled their intent to cut non-emergency medical transportation, which we also view as a critical benefit because you can't get the healthcare you need if you can't get to your healthcare provider. And so non-emergency medical transportation is a very unique and critical Medicaid benefit that we don't want to see reduced or removed at this time. But thankfully, the administration has really slow walked. They haven't taken any steps to actually eliminate NEMT. And so the last part of my presentation I just want to review quickly is the actions that the federal government and states have taken to help Medicaid respond specifically to the COVID-19 public health crisis. And so the two main things that I just want to cover, I think Congress has taken a lot of steps to increase access to healthcare and coverage at this time. But in terms of the Medicaid program specifically, the 2 points that I wanted to cover is that in the COVID-19 congressional relief packages, Congress has increased funding for Medicaid for states, but states can only take advantage of that increased funding if they preserve coverage for everyone who was enrolled as of March 18th, which was the date that bill passed. That's why March 18th is the date. But if anyone had Medicaid coverage as of March 18th, including people who were in the system to be terminated but hadn't been completely terminated, they should, or they're required to, states are required to keep Medicaid coverage for those individuals until the national emergency is over. And so I think that's an important piece of those relief packages that I wanted to mention. I feel like there's so much of the relief packages that's getting attention right now, but what they're calling a coverage moratorium, I think is really important. So anyone who has Medicaid right now should be able to keep it until the emergency is over. So what are states doing as a result? Many states, I was trying to find a good graphic to show states who have taken up the moratorium. It may be all states, but I'm not positive. But a lot of states have taken up Congress on their offer, and they're getting increased funding in exchange for keeping everyone covered. They're also making it easier for individuals who didn't have Medicaid coverage to get it by allowing individuals to self-attest to their eligibility information rather than submit paperwork at this time. States are also expanding in eligibility in minor ways. I don't see any state deciding to expand their Medicaid program at this time, but a lot of states are expanding hospital presumptive eligibility, or letting hospitals do eligibility determinations temporarily so that a person can get coverage and care, and the hospital can get paid quickly and easily. And then a lot of states are expanding access to providers and services, either by releasing emergency guidance that makes it easier for providers to deliver care, and also just expanding access to telehealth services so that individuals who still need routine care for their chronic condition, can receive it at this time. And then the last thing I want to touch on, because I know I'm running up on time, is what advocates can do. So right at the beginning of this crisis, or when the first congressional relief packages were being put together, Community Catalyst policy team sat down and thought, what are the things that we really want to see states do at this time, state Medicaid programs do to protect coverage and care, and came up of a list of policy priorities. And states are really doing a lot of these things: preserving coverage and protecting individuals from out-of-pocket costs. It's also a requirement in the federal congressional relief packages that Medicaid not charge any cost sharing for COVID-19 testing and treatment, really ensuring access to care for individuals with disabilities, individuals with substance use disorders, older adults, individuals who need reproductive health care, ensuring that there's policies and practices in place to make sure these populations can continue to get the care they need safely and easily. Reaching the remaining uninsured, so everyone has access to healthcare at this time. That's something we think should always be the case, but definitely during a public health crisis like this. And then really ensuring that states are putting health equity, health justice, and racial justice at the center of the healthcare policy decision making at this time. We're definitely seeing the incredibly disparate impact that this crisis is having on communities of color, and think that putting policies in place to help mitigate those disparities is crucial. And so one of the things we discussed is putting policies in place to make sure that providers who have been shown to reduce health disparities, specifically like community health workers, dental therapists, peer support specialists, doulas, making sure that they have the ability to deliver care safely, easily, and comprehensively at this time, is one of the examples. So that is where I'll stop and turn it over to Nicole and my fellow speakers. But thank you so much for having me, and happy to take any questions after this.
Thanks, Rachelle. That was amazing. And I think you did a great job of setting a really great foundation for Nicole, for what's happening on the state level. So I'll go ahead and pass it off to Nicole.
All right. Thank you. Yeah, thank you, Rachelle and Christina. Can y'all hear me okay?
Yes.
Okay, great. So I just really appreciate the long time partnership that we've had with NCAN and with Community Catalyst. So just really pleased to do this today. At the NC Justice Center, our mission is to work ourselves out of these jobs so we can do something else. And we plan to try to eliminate poverty by attacking it at its roots. And so I direct the health work at the Justice Center, and Lee's gonna help me with my slides. So I'm gonna talk, I'm not gonna cover things that Rachelle did really well, but so I might skip some of my slides, but just thought I would just start a little bit related to the impact of COVID-19 in this country. Next slide. And if you look at this slide that was presented on May 11th during a congressional meeting by Senator Kane out of Virginia, you see January 21st, looks like, you know, United States and South Korea have similar situations going on. Then you look at March 3rd, it looks like we're doing better as far as deaths. But then now look at May 11th. It's so striking. I mean, it almost looks like it's a typo, but if you just look at that, you can see that our response in the United States hasn't been what advocates believe it should have been. And so some of the key factors that we're hearing from health professionals is the testing, contact tracing, social distancing, and healthcare systems, and the way we did it differently, and the timing was differently in the United States versus South Korea. Next slide. I want to talk a little bit about the South and COVID-19. You know, related to health equity, we started talking about sort of the Black Belt and where slavery was prevalent, and just to think about where, if you overlay some of the maps about who's uninsured, who's doing more of the lower wage work, who's has less access to healthcare, but more access to other environmental injustices in the South. Let's see who that is. Next slide. And so you can go next, the next point. And so the next one. Thank you. And so people often talk about the urban areas that are, you know, more densely populated, and so there's more rapid transmission, as we see in areas in New York. But it is getting to rural communities, and I think about during natural disasters, people tend to, you know, be on camera saying, I'm going to ride this out at home in my house. And what we're fearing is that people are riding out this natural disaster in their homes, and that some even are trying to seek care and are told to go back, are turned away. And I was told yesterday by Representative Candy Smith out of Pitt County that 2 people in her that she represents were tried to get care and were turned away, and they passed away. So health inequities did not get better with COVID-19. Next slide. And that's just a map showing you sort of the what we're calling the county epidemic. Just look at all of the hidden transmission that we call it hidden because we're not sure. At some point, the HHS was not getting data, demographic data, and because we don't know who's actually recovering because of the way we are doing this, where everyone is not getting tested who believes they should be tested. And then we're asking essential, and I'm putting in air quotes, people to go to work, and we're not properly ensuring that they can. Next slide. You can hit the next. So, and I just wanted to show Louisiana, just a difference in, you can keep going. And Georgia, just a difference in the population and then who's passing away. You can go next one. The next one. The next one. The next one. It's just awful. Next one. Okay, and then I think next one is our state. And so when we first looked at this data, we African Americans are 22% of the population in our state, 35% of the cases that are positive that we were aware of. But about 3 weeks ago, we were at 22% of the deaths, and now we're at 36%. These numbers just keep growing. And so I just wanted to show you that we're going to work on other equity issues as well, but we're going to start out with African American folks at this time. So that was just wanted to show you all the impact. Next slide. And so Wilson County is an rural, can you go back for a second? Yeah, I wanted to show like Wilson County, the percentage of people of African descent are 40%, but 55% of the positive cases. And that's a rural community close to Raleigh, 45 minutes east. And then the next one, Mecklenburg County, where Christina is, I think Dante too, and just to show what's happening in a very urban, county too. And just, we're just not faring well. And then if you look at the Crude data, the death rate, and just visually look at that, we just got to do something. So I just wanted to show that visually, how we're doing in the state versus, and in the South with our population, and then with the percentage of how African Americans are faring with COVID-19. Okay, next slide, and we'll see what I need to skip over. I mean, here I think we could talk about the loss of employer sponsored coverage due to COVID-19, the loss of jobs, is over, you know, 1 million. And then if you look at, you know, the loss of employer-sponsored health coverage here at half of that. And so that means that we got people who are not eligible for Medicaid, as Rachelle spoke about. They're not eligible for the marketplace, even though loss of a job is a special enrollment period. But how many are uninsured? And so our number of people that are in the Medicaid coverage gap is going to grow exponentially. This just proves that insurance tied to work doesn't work. Next slide. So I think we already talked about this with Rachelle. Next one. And she already went through how North Carolina has, you know, a decent plan, the things that are optional that we have covered. Next slide. And so I want to talk a little bit about Medicaid during disaster, and Rachelle spoke a lot about the flexibility that we've been able to use under our current plan, and through waivers that have been, there's been 1135 waivers, 1115 waivers. Essentially this last one that I'll speak about, one of the provisions would allow people who test positive for COVID, whose incomes are at 200% of the federal poverty level, to get coverage. What I would say about that is that it would not go far enough. And I would say that because what was not clear in the waiver that North Carolina proposed is if people got coverage, you know, was it for limited coverage, limited care? Is it for what people are able to get on the current Medicaid program under our current state plan? But what's clear to me is that if you get a test and you don't test positive, it wasn't, well, I would say it's not clear whether you have maybe bronchitis or something else, or maybe you have asthma. Would you be covered? Would that test, cost of that test be covered? Would you be charged a copay? Would you be charged for treatment if you were previously uninsured and you went to this test and you were not positive? Another thing is, when you hear people talking now about equity, they say that people with underlying health conditions like hypertension, high blood pressure, or heart disease, you know, obesity, diabetes mellitus. Well, so now are we talking about people of color? What are we talking about? And so when you do that, so what you're saying is people who historically in this country do not have equitable access to healthcare. Now you're telling me that I'm also now at risk because of this condition that I have because I was not able to access healthcare, and maybe I was in a county, maybe I lived in Washington County or Martin County or Beaufort County, and now my access to a hospital is not the same for critical access or to a provider. In Swan Corner in area 3 medical providers last I checked. So now you're telling me that I'm more at risk for this condition, but I might be an essential worker, and I may have a low wage job, and I might not be getting hazard pay, and I might be uninsured. And now you're telling me I'm more at risk for this. I think that was just a ludicrous part of that waiver. I would not publicly talk against the waiver because it would provide access to people, but certainly amongst friends, including, you know, our guest here from a health plan, I think all of us would agree that we have to help people, support them if we're asking them to stay at home or to go to work. So I think Rachelle spoke about sort of the partnership between states and federal government, and let's see. And she spoke about, you know, with COVID-19, the context through the CARES Act. Next slide. Yeah, and we can stop there. Thanks. This is my time. This is all just about the Texas versus United States. It's a bill you probably heard about. And it's just another attack on the Affordable Care Act, and something that we just wanted you all know that we're watching and seeing where this goes. And we're not going to stop. You know, trying to prevent the attacks to the Affordable Care Act. So I think that's my time.
Thank you so much, Nicole. That was really great and so informative. There was a lot of information from both you and Rachelle. And one thing that I think is just startling to kind of glean from your presentation specifically was the racial health disparities that are present and how it was so unfortunately consistent across the southern states and likely throughout the country. And it's so disappointing to see that, and just shows like how much work we have to do to really promote health equity and really address a lot of these issues that the COVID-19 pandemic has highlighted, for sure.
Absolutely.
Yeah, real quick, I want to pass it off to George Cheeley. He is the Market Chief Medical Officer over at AmeriHealth Caritas, North Carolina, which is one of the managed care centers here. So I just wanted to give him a few minutes just to introduce himself and share a bit about the work that he's doing real quick. Go ahead, George.
Yeah, thank you, Lee, for the opportunity to join an important conversation about Medicaid in North Carolina. As Lee mentioned, I'm the Market Chief Medical Officer in North Carolina. I was born and raised in Raleigh, was away for school, and then came to Duke for training in internal medicine, and was a resident at Duke, and then was at Duke for 10 years, practicing as a hospitalist physician, and then also leading a lot of Duke's work to prepare for value-based care to really improve quality, reduce the cost of care. And so was excited about the opportunities Medicaid transformation might bring to our state, and excited to join a company that was really focused on tackling similar opportunities from a little bit different angle. And AmeriHealth, for those who may be a little less familiar, certainly as I was before I got to know the company, we've been around for 35 years. Our company has really focused on Medicaid, service to Medicaid. We work in 12 states plus DC, and are eager to bring the lessons that we've learned elsewhere around the country to really help some of our needy North Carolinians really get the care they need, help them to stay well. And a big part of our focus is really on getting local, on identifying organizations in communities that know the people that live and work in those communities, and really understanding how to address the health needs of the whole person. And so, I'm excited to work for an organization that focuses on helping people get more stable housing, helping people identify stable sources of food, along with understanding the medical issues that may make addressing some of those more basic needs even more complicated. So, I think for those who are somewhat familiar with the direction managed care for Medicaid is taken in North Carolina, we're currently under a suspension as the state's budget kind of remains hanging in the mix. And, now we're in the midst of a pandemic. And so, at least for me, the experience of interacting with the chief medical officers in other states to understand how some of those other states are organized to help support people navigate coronavirus, and to really help support members who might be at risk of infection to get the protective equipment they need, to make sure that they, again, have access to as stable of housing as we can arrange, and food to keep them healthy is an important part of what we do. So I'll stop there. I'm glad to take any questions kind of here representing AmeriHealth, but also general physician view, clinical view at the time of the coronavirus pandemic.
Thank you, George, for sharing. Thank you so much. I'm going to pass it off to Lee real quick. I think you have a podcast clip you want to share.
Yeah, so as we move toward closing out, wanted to share one resource that has come out of some of the work we've been doing with this Medicaid Ambassador Project. So if this had been a normal time, we probably would have been hosting this as an in-person town hall conversation. And one of the goals of our town halls has been to use them to sort of leverage and engage conversations in the broader media around Medicaid. So Jeff Mills, who's one of our Medicaid ambassadors from Wilmington, and I wrote a piece that he recently recorded for a podcast based in Wilmington, North Carolina, that featured some information about the Medicaid program. I'm going to play a short clip from it. We'll send the full clip out from Matt Martin later this afternoon with all the resources from this, but wanted to give him a shout out and feature a little of those remarks.
Here in North Carolina, the state has requested waivers from the federal government on many restrictions to better respond to the epidemic. The requests include waivers to restrictions on how long someone may stay at a hospital and other screening and enrollment requirements. It's excellent that this program can have this versatility in a time of crisis. It also calls into question the many restrictions and limitations on access that have been proposed for the Medicaid program in the past in North Carolina and other southern states in recent years. Just last year, a proposal was introduced, though it did not pass in the North Carolina General Assembly, that would have required all able-bodied North Carolinians who receive Medicaid to meet work reporting requirements. Sounds pretty backward right now, doesn't it? Moments when someone's job stability and income are in flux is exactly the kind of time that you need the guarantee of health insurance, whether we are in a public health crisis or not.
I'd love to play the full piece, but just wanted to give a quick sort of highlight of that discussion. You know, I'd reiterate what all of our speakers have said. We really think the Medicaid program is such a crucial one, and really in this public health crisis, I think there's an opportunity to further illuminate and further really push back in some ways on some of the restrictions that have been discussed in North Carolina and across the South in recent years. So Jeff, thank you for helping put that together with me. We're excited to share it and promote it this week, and would invite all of y'all on the call. If you're interested in sort of being more active ambassadors and advocates for Medicaid, don't hesitate to reach out to Christine or I to talk about that. So Christine, I'll pass it back to you.
Yes, so we have 4 minutes. I know that there have been some questions that have already been asked and answered in the chat box, but do people have any other questions that haven't been answered that they would like to quickly ask real quick? Okay, well, I'll just squeeze one in since everyone's being shy. Rachelle or Nicole, I guess y'all can both answer this. But I was hearing a lot about how the US and certain states have been, I guess, lying about the death tolls related to COVID, or stretching the truth out on the amount of deaths, and then people being able to, like, people who have like died of other causes, you know, been not counted in the final death count. What can we do to help mitigate that? Because I feel like when it comes to collecting accurate data from this time, that's something that concerns me. So I feel like a lot of people are getting lost in that shuffle.
Yeah, I think that's a great point, and I don't know that I have a great or novel answer other than just pushing for better data collection at the state level, because I think it can be more detailed. I think states just have a greater, or should have a greater interest in making sure their own data is comprehensive and sound versus the federal government. So yeah, that's my immediate thought.
Nicole?
This is George. I'll just add also that testing availability is a critical part of capturing those COVID-19 related deaths, and the availability of testing has varied dramatically across states, and I would imagine also varies across different ethnicities as well. And so, you know, I will emphasize that for many reasons, including ability to trace close contacts and monitor outbreaks, that advocating for availability of testing for everyone with symptoms and for those who may have had close contacts is going to be a really important part of combating the epidemic moving forward.
Yeah, I'd agree with that too. And I'd also say for folks who may not have stayed at home as much as we were encouraged to in the beginning, when we were not in phase 1, moving towards phase 2, I think the more you get out there, the less apt you're going to know all the people you've been in contact with too. So I worry about that as well. I serve as a mayor pro tem in Apex, so I helped write the Wake County order. And so, you know, I had to think about it in different ways, and I had to be home too, you know, so I do worry about that. And I think that I wrote that down. I think our advocacy with HHS and the governor's office are places to start, just to remind them about how important data is, and how important it is, like you said, for health equity. This is the moment. I mean, we have not been able to get a lot of things done. And now all of a sudden, because COVID-19 doesn't care what your zip code is as much, and as politicians tend to, now we're trying to figure out how we can like waive prior authorizations, how we can like have telehealth and all that, you know. And so I want us to figure out how in the advocacy community, how we can preserve some of these things that are good, that we see that Medicaid is able to do, how we preserve some of these things, and other insurance companies haven't been able to, how we preserve some of the good steps that we've made, you know, during this time, and how we reject some of those things that were just for the moment.
So true, so true.
Mm-hmm.
I feel like, you know, on staff, we've been talking about how work requirements now sound so silly. They sound so silly in the world that we're in. It's like, we can't work right now. What are you talking about? But I just want to say thank you to you, Nicole, and Rachelle, and to George for sharing today, and for educating us and getting us up to date on what's been going on with the program and steps that we can take to advocate for the program and to protect the Medicaid program. I just want to thank you all for spending your time with us. If you look in the chat box, you'll see the link to the full podcast. You'll see the link to the video. You'll see the link for next week's webinar, which will be on COVID-19 parallels and long-term survivors. I'm not sure, Lee. Okay, that's the correct. All right, so that'll be really interesting and a really great conversation. So I encourage y'all to join us for that. But without further ado, if you have any questions, feel free to email me, and I'll pass them back over to Rachelle and Nicole. And I want to thank you all again for joining us. We will share the recording, the slides, and all of the resources out via email afterwards. All right. Bye, everyone.
Thank you.